It is a gorgeous day in San Diego. It helps thaw out all our friends from Boston. We're talking about the optimal length of DAPT. Well, it's still being debated, but we're looking at a slightly different question at the moment. We're here at ACC 15 looking at what's the significance of interruption or any non-adherence DAPT during the prescribed 12 months of therapy. And I'm with Donald Cutlip, MD, who is Director, Cardiac Catheterization Laboratory, Beth Israel Deaconess Medical Center, and Professor of Medicine at Harvard Medical School. This is coming up in the Journal of it's a JACC Interventions piece in March 2015, thrombotic complications associated with early and late non-adherence to dual antiplatelet therapy. First, what's the EDUCATE registry?
EDUCATE registry was a post-market approval study for the Endeavor sotavolumous-eluting stent. Patients who were eligible from EDUCATE would eventually be randomized into the larger DAPT study. But in the registry, we're also looking to answer some other questions. So we actually enrolled a pretty much all-comers group with some exclusions that we knew would not be later eligible for randomization, such as warfarin therapy and high bleeding risk, because we really wanted to look at this issue of non-adherence, and bleeding, of course, is one of the factors that would contribute to that the most.
Exactly. And so you did this study trying to answer a specific question, not the optimal length of therapy, but more just what happens when it happens.
Exactly.
Okay, so how many people were you looking at, and how many are in the registry?
Right. So we ended up enrolling about 2,200 patients, and of that group, about 11% had any non-adherence during the first 6 months, which was the endpoint or time of endpoint that we chose. But we followed all patients for the full 12 months, so we could look at any non-adherence on a time-dependent basis in that first 6 months, but also within the first 3 months, between 3 and 6 months, and then after 6 months as well.
Now, these are a fairly large group of patients, and we know from previous work that physician interruption is always a little safer, it seems, than just patient interruption, patient non-adherence. What did you find?
Well, we weren't able to look at physician interruption. We didn't assess that endpoint specifically, but we did find that major bleeding was a major, significant effect modifier on the effect of non-adherence, similar to what was shown in the Paris registry. We did, though, show that any non-adherence, even without bleeding, was also associated with a 2 to 3-fold increase in death or myocardial infarction. But if you added major bleeding to that, so any non-adherence because of major bleeding or in association with major bleeding, further increased that risk by about 5-fold. So about 35% of patients who bled, had non-adherence, went on to have death or myocardial infarction in the first year.
I mean, one of the take-homes I take from this is that it's pretty encouraging that the numbers were as small as they were during the 6 months.
For non-adherence. Well, but you have to keep in mind, this was a clinical trial.
Yeah.
So patients are being monitored very carefully. In Roxana Moran's Paris registry, that number was about 23% for non-adherence in the first year, but also about 10% due to major bleeding. So I think that proportion is similar, but we probably had a little bit better compliance because it was a clinical trial where patients are being monitored pretty carefully.
So what are you taking away from this?
Well, I mean, I think we know that prolonged DAPT is the answer overall, but for patients who have to stop, it seems to be that 6 months is a critical time point. There have been some studies suggesting it may be shorter, even as short as 31 days, but I think those studies were difficult to interpret because the numbers stopping between 0 to 3 months and 3 months to 6 months were actually quite small. We did show that after 6 months, the effect seems to go away. Death or MI rates.
Which is encouraging.
Very encouraging. I think that's very encouraging. But it does seem that first 6 months is important. And I think it's very important that if you enroll a patient at high risk for bleeding, because it seems to be something special about bleeding plus non-adherence. You know, maybe bleeding's confounding the whole issue, but it's hard to tease that out. So that combination is very critical. So if you know a patient's at high risk for bleeding, it may still be that a bare metal stent is the best choice so that we know we can shorten that DAPT duration.
And if you have a patient you know is high risk, if it's possible, does more education, is that an opportunity to actually make sure you emphasize to the patient, this is critical, please call me before we stop doing something?
Because it does seem that any non-adherence, even without bleeding, is still important. The problem is the bleeding, because obviously the patient can't control that, so that's up to us.
Right.
You know, we need to be able to assess that risk
But if something happens, call us.
Exactly.
Don't be a stranger is the issue.
Don't be a
there.
stranger, yeah. And don't stop the drug without talking to your cardiologist, of course.
And this is the March issue of JAK Interventions and its thrombotic complications associated with early and late non-adherence to dual antiplatelet therapy. For Cardiol Source World News, I'm Executive Editor Rick McGuire.